Hello once again. This is our last topic for respiratory critical care, and that's mechanical ventilatory support. So again, to review the two basic types of respiratory failure, that's the hypoxemic and the hypercarbic. Hypoxemic, if the oxygen saturation or the arterial oxygen pressure decreases below 90, or the saturation is below 90% despite an increased inspired oxygen fraction, and this usually results from ventilation perfusion mismatch or shunting. On the other hand, hypercarbic respiratory failure results from an elevated arterial partial pressure of carbon dioxide, usually more than 50 millimeters mercury. And the underlying condition that would produce this problem, the ones that would decrease the minute ventilation or increase in dead space. For the indications of mechanical ventilation, acute respiratory failure with hypoxemia, as what we see in ARDS, heart failure with pulmonary edema, pneumonia, sepsis, and complications of surgery and trauma. The other indication is for the other type of respiratory failure, and that's produced by coma, exacerbations of COPD, and neuromuscular diseases. The primary objectives of mechanical ventilation is to decrease the work of breathing and to reverse the life-threatening hypoxemia and progressive respiratory acidosis. So there are two basic methods of mechanical ventilation. The first one is the non-invasive ventilation, or the NIV, and the next one is the conventional ventilation. For the non-invasive ventilation, we utilize for the patient interface, a tight-fitting mask. These are the different types of face masks. Or we could be using a nasal mask, a helmet, or a hood. And ventilation is implemented as pressure support, as continuous positive airway pressure, or a bilevel positive airway pressure. Highly effective in patients with acute respiratory failure arising from exacerbations of chronic obstructive pulmonary disease and from pulmonary congestion. However, the major limitation for non-invasive ventilation is intolerance, because it could be very uncomfortable to be wearing a tight-fitting mask with air blowing through it. The contraindications for non-invasive ventilation are as follows. You could review this in table 295 of Harrison's. So for the conventional ventilation, we insert a cough tube, the cough is here, into the trachea to allow gas to be delivered to the lungs at pressures above atmospheric pressures. So the principles of mechanical ventilation is that once the patient has been intubated, the basic goal is to optimize oxygenation while avoiding ventilator-induced injury. And this is injury produced by the overstretch and the collapse and re-recruitment of the alveoli. So with this approach, we call that the protective ventilator strategy. Although normalization of pH is desirable, there is a risk of lung injury associated with large volume and high pressures needed to achieve this goal. So in the interim, we would allow permissive hypercapnia to happen. So to demonstrate clearly the protective lung strategy, in this volume pressure curve, point A is the lower inflection point and point B is the higher inflection point. Values below the lower inflection point, such that would be a pressure below less than 20 centimeters of water, the alveolar would tend to collapse. On the other extreme, at pressures more than 30 cm water, the alveoli would overdistend. If you want your alveoli to have just the right amount of distension, you have to keep the alveoli in the protective alveolar ventilation, and that's establishing your PIP at the lower inflection point and giving volumes that would not produce pressures more than 30 centimeters water. So the different modes of ventilation are, the mode is the manner in which the ventilator breaths are triggered, cycled, and limited, while the trigger is what the ventilator senses to initiate an assisted breath, either an inspiratory effort of the patient or a time-based signal dictated by the machine as programmed by the operator. The cycle is the factor that determines the end of inspiration, and the limit is what the operator specifies. That value will dictate the airway pressure or the airflow or the tidal volume. So the more common modes of ventilation is the ACMV or the AC mode, assist controlled ventilation. The inspiratory cycle is initiated by the patient or by a time trigger, and every breath delivered consists of the operator's specified tidal volume. So say you want a tidal volume of 400 mils, and then the ventilator rate is dictated by the patient's own respiratory rate, or the backup could be specified by the operator. The advantage of the AC mode is it ensures a backup minute ventilation in the absence of an intact respiratory drive. The disadvantage, however, is that respiratory alkalemia, if the patient is tachypnic, would ensue, and there could be dynamic hyperinflation or autopeep, leading eventually to decreased venous return. So the other form of mechanical ventilation is the intermittent mandatory ventilation. Here, the operator sets the number of mandatory breaths of fixed volume. Between those breaths, the patient can breathe spontaneously. So in the synchronized intermittent mandatory ventilation, with a set number of breaths per minute, the ventilator would assist. But in between these assisted breathings, the patient is allowed to have spontaneous respiration. So for the synchronized intermittent mandatory ventilation or the AC mode, there's only a preset number of breaths that the ventilator may assist. The advantage is that it allows patients with an intact respiratory drive to exercise inspiratory muscles between assisted breaths. The disadvantage, however, is that it could be difficult in patients with tachypnea because they may attempt to exhale during the ventilator-programmed inspiratory cycle. The other mode is pressure support ventilation. This is patient-triggered, flow-cycled, and pressure-limited. This differs from the other two modes in that the operator sets the pressure rather than the volume to augment every spontaneous respiratory effort. Inspiration is terminated when the airflow falls below a critical level, and the patient receives ventilator assistance only when the ventilator detects an inspiratory effort. The other forms of ventilation is the pressure control ventilation, which is time-triggered, time-cycled, and pressure-limited. The inspiratory pressure is specified by the operator. The tidal volume and the inspiratory flow rate are dependent variables. And this is the preferred mode for patients in whom it is desirable to regulate peak airway pressures, such as those with barotrauma and for post-thoracic surgery patients. Another mode, but not so commonly employed, is the inverse ratio ventilation, which is a variant actually of the pressure control ventilation that incorporates the use of a prolonged inspiratory time with the appropriate shortening of the expiratory time. This is used in patients with severe hypoxemic respiratory failure and works in conjunction with PEEP to open collapsed alveoli and improve oxygenation. So again, you review this on your table 295-2, a table that demonstrates the different ventilatory modes, the variables set by the user, the variables monitored by the user, the trigger, the cycle, and the limit, advantages and disadvantages. So we go back to the protective ventilatory strategy. This just means to say that the set tidal volume is close to 6 mL per kilogram of ideal body weight or predicted body weight. You do not overdistend the lung. You prevent the plateau pressure from exceeding beyond 30 centimeters water. You use the lowest possible FiO2 to keep the oxygen saturation at 90% or greater. And you adjust the PEEP accordingly to maintain alveolar patency while preventing overdistension and closure and reopening cycle. So what do we do during mechanical ventilation? As mentioned in the previous 2 lectures, general support would include sedation and analgesia to maintain comfort. To achieve this, we give benzodiazepines and opioids. Because ventilated patients are prone to venous thromboembolism, we would like to prevent that by giving heparin or pneumatic compression stockings will be in place. Because they are so stressed, decubitus ulcers could happen if they're maintained in one position most of the time. To address this, frequent position change is advocated, and provision of air mattresses could also help. And these patients are also prone to gastrointestinal injury, so we give prophylaxis against this by the giving of your H2 receptor antagonists, antacids, and the cytoprotective agents like sucralfate. And then to give the adequate nutritional support either by NGT or hyperalimentation. So the complications of mechanical ventilation would include barotrauma, nosocomial pneumonia, oxygen toxicity, tracheal stenosis, deconditioning of respiratory muscles, hypotension, and stress ulcers. With better nursing care, these complications may be prevented. Now, as mentioned in the initial lectures, every time you do visit an intubated patient, you always screen the patient for weaning. So you would know when to wean. And these are the clues that you have there is that if the lung injury is stable or if it is resolving, if the gas exchange is adequate with low PEEP, at least a PEEP of less than 8 or 5 centimeters water, and if the fraction of inspired oxygen is less than 50%. So if the hemodynamic variables are stable and the patient no longer needs vasopressors, then you may try to wean the patient. And if the patient is capable of initiating spontaneous breaths. So if the patient is deemed capable of beginning to wean, perform a spontaneous breathing trial. This trial consists of a period of breathing through the endotracheal tube without ventilator support. You could give a CPAP of 5 centimeters water with or without pressure support, or just let the patient breathe on the TPs. In your attempt at weaning, you may not be successful because if you notice the following parameters, failure of the spontaneous breathing trial is likely. So if the respiratory rate is more than 35 cycles per minute for more than 5 minutes, if the saturation would drop below 90%, if the heart rate is so fast at more than 140, or you have a 20% increase or decrease from baseline, the patient is having a hard time liberating, weaning from the ventilator, or if the systolic blood pressure falls below 90 millimeters mercury or would rise to as high as 180, and if there is increased anxiety during the act of the spontaneous breathing trial, or the patient would demonstrate diaphoresis, then there's failure of the spontaneous breathing trial. So reassess the patient for the following day and try to look for the reasons why the patient could not tolerate the spontaneous breathing trial. So there should be a daily WEAN screen. Check whether the underlying disease has resolved, whether there is adequate gas exchange, hemodynamics are stable, is the patient breathing spontaneously? So if yes to all this, then start spontaneous breathing trial. If the patient would pass, assess for extubation. And when you assessment for extubation, the patient still pass, then you take out the endotracheal tube. But if the patient would fail, consider tracheostomy. And also if the patient fails the spontaneous breathing trial, continue with the mechanical ventilation and treat the reversible elements. And again, the following day, repeat the daily screen. What to watch out for if you could not wean your patient? If you are prolonging, if the mechanical ventilation is needed for a prolonged period of time, then you have to warn the patient or their significant other of a possibility for tracheostomy. So 5 to 13% of patients will go on to require prolonged mechanical ventilation, prolonged being more than 21 days on mechanical ventilation, but as early as 10 to 14 days, and you would foresee that the patient would still need mechanical ventilation, then they should be appraised for tracheostomy. Because tracheostomy would be more comfortable for the patient, you would require less sedation, and the airway would be more secure. And when you attempt to wean, the weaning time could be reduced. So, however, it comes with its own set of complications, like it could set in 5 to 40% of cases. Commonly, there would be bleeding. Cardiopulmonary arrest could happen during tracheostomy. Hypoxia could happen during tracheostomy. And the procedure could produce structural damage. Pneumothorax could happen. Pneumomediastinum could happen. Wound infection and erosion of the innominate artery. So that ends now our discussion about respiratory critical care. For any questions, you may reach me through your department chair, Dr. Mercy Litihiuoy. Thank you for listening.